Thank you so much, Jordan, for that wonderful, warm introduction. And welcome, everyone. Thanks for joining Navid and I for our presentation, and hopefully some discussion as well today around anti-racist CANS assessment. So Navid and I actually work at the San Francisco Department of Public Health, specifically Behavioral Health Services, and the specific division is Children, Youth, and Family System of Care. So as much as a lot of our sharings today may also apply to any TCOM tool, our focus for today is really looking at CANS assessment and our journey around it in terms of really highlighting anti-racist practices. We have no financial disclosures or financial relationships to disclose. These are our learning objectives, which you already also saw at the flyer or announcement for this presentation. So let me ground us first in terms of when we think about like assessment and QI, that comes after really aggregating assessment protocols and really representing the data of our assessment to have conversations in our system. We often ground that work in pillars in our use of assessment and QI in our system. Aligning our work with our department's racial equity plan and also our trauma-informed systems. Now, one of the principles of trauma-informed systems is really that extent of like collaboration versus a top-down or hierarchical way of like processing. So in our system, we try our best to really be very collaborative in terms of our assessment processes. And most of the time it's informed by this new paradigm, which in the past 20 years has been about collaborative or therapeutic assessment. In our use of QI tools, we often lean into Lean and Six Sigma and many other QI tools, but integrating them with research or evaluation practices that are culturally responsive and participatory and also indigenous. So for example, in thinking about how to tell stories around data, what we have really strengthened in our system since 2015 is a very cohesive, comprehensive data reflection process. We're in very similar to talking circles in the Native American tradition, coming together to talk about data and reflect on the data in a way that it could help inform practice improvement. So how do we adopt and adapt a race equity lens in our assessment processes and subsequently QI processes? To become anti-racist, you can start with an internal reflection of where you are in the journey to be anti-racist in the work that you do. As a clinician, maybe as a supervisor, an analyst, a QI lead, or a program director. So for example, as a clinician, you may introspect that probably you are still in the fear zone, or you are still in denial of racism as a problem for many of your clients, and you are not really comfortable delving into assessment questions that capture the experiences of racism by your clients. Or probably you're in the learning zone, wherein you're more open to really having difficult conversations with your clients around race or racism. It makes you uncomfortable, but included in your assessment is really asking your clients questions or difficult questions such as how they feel being in a relationship with you when you or your client may belong to different racial or ethnic groups or might have different backgrounds based on your diversity. Or probably you're in the growth zone, wherein you're able to sit really well with the discomfort, but are really pushing yourself to engage in difficult, constructive conversations with your clients around race or racism. Becoming anti-racist in the way you navigate assessments with clients requires intentionality and deliberate practice. According to Dr. Hallman, especially in working with Black, Indigenous, people of color communities, assessment should not be hierarchical or top-down process, but it needs to be a collaborative process where expertise is shared between the client and the clinician. At the same time, assessment should not really be a process of using assessment tools to label clients, but should be a positive, strength-based opportunity by which you help a client discover who they are, discover themselves through the assessment process, and reauthor their lives. Dr. Hallman recommends the use of therapeutic assessment as an anti-racist approach to make the assessment process more transparent and collaborative, especially in working with Black, Indigenous people of color clients. As such, assessment then becomes an intervention in and of itself. For example, in doing the CANS, a client can be involved in the CANS ratings, as well as in using the CANS scores for collaborative care or treatment planning. This approach is not something new. If you go back to the vision behind the CANS and many other TCOM tools, as really they are ultimately communiometric tools that are storytelling tools. John Lyons always says the CANS is a measure or a tool that captures a client's story. So when you're trying to listen to the story of the client, they come to you as many rivers, wherein the story of the client can come from the client themselves, can come from the family of the client. So in working with children or adolescents, potentially their parents or their caregivers, you could also hear their story from the perspective of their teachers or many other support people in their environment. And your work as a clinician is to organize all those multiple rivers of storytelling into one ocean. And the process of integrating these many rivers into one ocean or many perspectives into one story owned by the person who is living it is person-centered care. And the integration of stories is simply good care. We also have to remember that storytelling around the world and across many cultures is not necessarily verbal, linear, or captured by rating scales. As we gather stories from our clients and their families, especially with Black, Indigenous people of color communities, we need to find ways to integrate other ways of storytelling, which could be Indigenous ways of storytelling using journey sticks from the Native American or Aboriginal cultures, or using music or even dance as a way to really highlight stories from particular cultures, or the use of metaphors, which we know across the world are very powerful, culturally based ways of really symbolizing stories and also experiences of the clients that we meet. We can collaboratively work with our clients to really put together their CANS story in many forms which are not necessarily verbal or linear. So it could be in the form of a fable. This is just one example, and really this was the focus of my presentation and Farah Farman too 3 years ago when we presented in the TCOM in terms of other ways by which you could really capture the CANS assessment story of a client. So using the lens of therapeutic assessment, we could work with a client to help put together like a fable that really capture many of their CANS and strengths, embedded into a fable that could really engage the client in understanding their story, but also really using it for treatment or care planning. We could work with the client, especially with children, in representing their story in a sand tray. So this is another example with a client I work with, wherein the different choice of miniatures really represent many of their strengths, at the same time needs in the CANS that are actionable, and also those that are being like worked from like a preventive standpoint. Or similar to really from a Native American Aboriginal culture, representing the CANS story as like a journey stick. Where as you put like objects in that journey stick, a lot of the objects could also be representative of many CANS actionable items. In working with Black, Indigenous people of color communities, many times stories about their race and our cultural background are not sufficiently captured in our assessment. They become the elephant in the room. Maybe part of it is us as a clinician being in the fear zone. And the challenge is for us to find ways to really move ourselves beyond the fear zone, more towards the growth zone in this anti-racist work. It could probably start with making sure when we are using the CANS assessment, we have several CANS cultural items in our assessment, like the CANS cultural stress item. And that could be in ourselves a prompt to prompt us to ask questions about our client's cultural background in our assessment. But that's just the baseline. There should be more work around it in terms of really follow-up questions, in terms of really capturing the story behind what's represented in the CANS assessment. So for example, in our San Francisco CANS, after a clinician has made their rating on the cultural stress item, there is a prompt there to really allow them to ask the client what is the source of that client's cultural stress experience. And using the frame, Pamela Hayes' addressing framework, really finding out what aspect of the client's diversity really heightens or contributes to the story around their cultural stress. Is their cultural stress based on their race or ethnicity, potentially experiences around racism or discrimination? Or is it based on sexual orientation, gender identity, or many other aspects of one's diversity? It's interesting to know that as we gather all of these stories together as well into an aggregate, what we have found is that for particular clients, like for example, our Latina, Latino, Latinx, or Latine, and Asian or API youth population, in their experience of cultural stress, it's mostly influenced by their race or ethnicity in combination with issues around language and also their socioeconomic status. For Black, African-American, or African-descended children or youth, most of the time their experience of cultural stress is tied to their race or their racial background. So really talking about experiences of racial traumatization, racism, or even like microaggressions in their community and their environment. Now, pulling all this together, it's really the question, how do we adopt and adapt a racial equity lens when we are pulling all together these stories to have an aggregate way of storytelling around our CANS assessments? So in our quality improvement efforts, we are often informed or we leverage currently existing racial equity tools around the US and also from outside the US. One that we particularly use routinely is the one from the Massachusetts Department of Public Health. And they put together this racial equity data roadmap, which we follow to help inform our quality improvement and also evaluation processes around the CANS. Using this map, we have identified our QI improvement project that is CANS related. Using the racial equity data roadmap, our journey started with really understanding racial or ethnic disparities in our outcomes data, not only with our CANS data, but any data in our system that really speaks to the race or ethnicity of our client population. So using that data roadmap, our story started with really understanding penetration rates. For example, our data stories on penetration rates or the extent by which we serve specific populations highlighted that we are not reaching Asian American, Pacific Islander, and Latina, Latino, Latinx, and Latina populations as much as our white client populations. Using that, we try to understand through focus groups and also communications with providers, really understanding what are the root causes of those disparities that we see in our penetration rates in our system. And using other sources of data to uncover causes of the differences, we really delved into talking circles or like focus groups. We're in really talking to providers and also client populations in terms of what's behind or what's the underlying story behind low penetration rates for specific populations. We use a root cause tree, or also many times we have used like a fishbone diagram. But what we found is one story that was prevalent in our focus group discussions is that we have low penetration rates because of issues around racial or cultural matching. And this means that the racial or ethnic makeup of our workforce, that includes our staff and also our providers who are clinicians, psychiatrists, and many other behavioral health providers, do not sufficiently mirror the race or ethnicity of the community we are trying to serve. And that might explain a lot of the low penetration rates because of really the skepticism or the difficulty or the challenge for our client population to really engage with them feeling that our workforce does not mirror really who they are in terms of race or ethnicity. And so based on that, what followed is a journey for us to understand how stories around our data around cultural matching is related to our CANS stories, and whether what is existent as cultural matching between our client population and our workforce has implications in terms of improvements of clients in their CANS stories. So as part of our data storing around this, it really requires for us presenting data in ways that help people make sense of the numbers. And also understanding that beyond the numbers, it's really creating this environment, this holding environment of storytelling, knowing that what is central to the lives of many Black, Indigenous, people of color communities is a mechanism of not just talking about data, but capturing stories. And we know across the world, storytelling can come in the form of like folklores or folk tales, stories in song, in dance, or even like poems. So it's really like having this paradigm shift of moving this stance towards data as having almost like this picture of like deer in headlights, to really creating like a warm environment of really having great conversations and storytelling around data. And in our website, and the link is in your handout, you could reference it there, is really some of our tools around data reflection and how we hold those in data reflection circles. So some of them, I'll give an example. We use, for example, a storyboard approach. Instead of directly asking questions around the numbers, the improvement rates around our cans, it's really using this lens of storytelling, like asking questions, what's the story here? Asking questions which are typically questions we ask around stories. Who are the heroes, heroines, sheroes, or theros in this story? Who are the villains? What are the conflicts in the story? Are there resolutions to this conflict? How did the story begin or end? So for example, in here you see a chart, and this was created by our quality management department in San Francisco Department of Public Health. It shows here a chart wherein the gray bars signify the prevalence rates. So how many clients in that particular program have actionable needs around a specific CANS item. And in the teal bar shows you there the rate of improvement when you're comparing the two most recent CANS assessments. So in here, in showing this data or bringing this data or chart to a program, we ask the question, what story do you see here? What story resonates with you as you begin thinking about your clients or the clients that you serve? And I remember bringing this to one program wherein a couple of clinicians talked about the story of a dragon. Like they talked about how most of their clients, when they first enter treatment, they are like dragons that breathe a lot of fire. And they present with a lot of anger, and they have referral questions, having a lot of impulsivity or hyperactivity in their presentation in schools and in the community or even in the home. And they are just these dragons, just breathing a lot of fire. However, as the relationship becomes stronger, then in further CANS assessment, what comes as a really prevalent need for the client is really around trauma, because underlying that story of like anger and impulsivity and a lot of behavioral problems, it's really complex stories around trauma. So for me, that was like a beautiful story of really how this data, after asking about the story behind it, a couple of these clinicians in the program really were able to enter the realm of a metaphor of really representing what this data is really saying about their client population. We also use Sandray processing. So instead of thinking about charts as data, imagine almost that they are like Sandrays, and you process them the way you would process Sandrays with your clients. Wherein instead of asking questions about what are these numbers meaning, asking questions about where is the energy here? And what is happening in this scene? If you were to give a title to this chart, what title would it be? Again, capturing that storytelling lens. So aside from storytelling around the CANS, we are also really highlighting here storytelling around cultural match. And because we're trying to show you for this presentation ways by which we are relating them or finding associations between the two of them. We know from the literature on cultural match, a lot of populations, specifically Latina, Latino, Latinx, or Latina Americans, and Black or African American or African descended clients prefer to be matched with their provider or clinician. However, beyond the importance of cultural matching in initial engagement and also initial access, across many meta-analytic studies on like cultural match, there is little evidence that therapeutic outcomes improve as a result of racial or ethnic matching. And it is this hypothesis that we tried to check in our system whether this is true, that really cultural match does not impact outcomes. Because what we hear from many of our providers, even in data reflection circles, is that, of course, cultural match impacts like outcomes, especially for Black, Indigenous, people of color communities. And I'll pass it on to Navid for the rest of the presentation.
Hey everyone. So what we have here is a chart of match for
all staff across 30 San Francisco programs. This chart specifically is going to compare the percent of unique clients to the percent of staff full-time equivalents or FTEs. The designations you see are based on the Casper guidelines. So we've got the Hispanic/Latina OXE, which is abbreviated as Latina OXE. And we got the Black/African American. We got the NHOPI, which is Native Hawaiian or other Pacific Islander. American Indian/Alaskan Native, and then the decline to state, other or unknown, is there at the bottom. So what we see here is that about 37% of clients are Hispanic or Latina OXE. So our most common clients are less likely to walk into a clinic and see someone that looks like them, or even be treated by someone that looks like them. On the other hand, 28% of staff FTE are white, when only 11% of unduplicated clients, which is the fourth highest, identify as white.
And really beyond just looking at that data in terms of like aggregate categories of looking at race or ethnicity, if we are to follow the racial equity data roadmap, one of the recommendations in understanding disparities in our outcomes based on race or ethnicity is to really disaggregate the data. Because sometimes stories around disparities might be missed if it's on aggregated global categories of like race or ethnicity.
Right, thank you, Ritchie. So to supplement that, there's groups like the Asian, the Hispanic or Latino, and the white, where there's a wide variety of subgroups within that main category. So we have a breakdown of match within the full report, but here's just an example of our Asian clients. So the percentage you see here are of Asian clients and staff only, and it's not amongst all of CYF. So we're saying here that 70% of our Asian clients identified as Chinese, which is an overwhelming majority of our Asian CYF clients. And to match that, we also have a majority of our staff FTE identifying as Chinese. And what's interesting is that even though they both make up the biggest proportions, there still seems like a large gap between the two, so we could maybe put more effort with the Chinese FTEs.
So you could see in there that we almost miss the story if it's on an aggregate level. Because in here, in this first chart, you see that there's almost no disparity, right? It seems that for most of our Asian clients, they enter a system wherein they feel represented in terms of the race and the Asian identification of our workforce. But in fact, when you look at disaggregated data, you could see their disparities, especially for our most represented client population.
So how do these data stories change through time? So we've got these longitudinal charts that portray time vertically, horizontally, and with color. So I'll walk you guys through how to read these. This is only representative of 8 of those 30 programs, which are civil service programs. So ideally, we want these dots to be as close to the midpoint as possible, which is 0% difference between the two. But we can also acknowledge that the right side of the chart in green still works as well for matching, because it represents the area where there's a greater percentage of staff FTE compared to clients. So how to read this chart is you start with the yellow dots. So for any race or ethnicity in FY 17-18 or fiscal year 2017 to 18, the difference between percent of clients and percent of staff FTE for Hispanic/Latina OXE was about 11% favoring clients. We move horizontally to look for a blue dot. So in FY 18-19, the difference narrowed to about 9%, still in favor of clients. Next, we move down for the following fiscal year comparison and staying with blue, and then moving horizontally, looking for the red dot. In FY 19-20, the difference widened to almost 14%. And then the purple dot tells us the gap slightly widened again in FY 20-21 at about 15%, all remaining in favor of clients. So over time, it looks like there's been an effort to match ethnicities, but the Hispanic, Latina OXE clientele have been mostly lost in that match effort. We also want to point out that the difference could be due to staffing But we have to take into account that during the pandemic, there might have been plenty of clients who did not or could not seek services.
And it's also good to point out here, let me just add as well, like when we brought this longitudinal storytelling to some of our programs, like, for example, when you look at the trends for African American and see that, oh, we are close to it really improving in our cultural match. However, what we heard as stories from some of our providers is that, yeah, that's true if you look at our staff in general. However, if you look at our clinicians, many still talk about, and many clients also speak to this, the lack of Black or African American identified like clinicians, like especially Black male psychologists or like therapists, as really something that we are missing in our system.
That's true. Thank you, Rich. And I will expand a little bit more on that later in the presentation. So once again, we can see that these charts look like with the subgroups. This chart further captures the need in CYF civil service programs for more Chinese identifying staff or clinicians. On the other hand, there used to be a need for more Filipina OXA staff, but now there's an overabundance, it might seem, in CYF. So what is the impact of cultural matching on CAN's outcomes? So these charts are going to look different. So once again, this is across all of CYF, but instead of looking at the unique or unduplicated clients, we're basing these on the client episodes. So if a client was discharged and then readmitted again within the same fiscal year and was able to squeeze in a second CANS assessment within 90 days, we made sure to include them in this analysis. We have a total of about 459 client episodes, which accounted for about 5,884 actionable items during their initial assessment. The initial assessment, which we refer to as T1, and then T2 will be referred to as the second assessment, which was the latest one within our data. And that latest one had to be at least 90 days later, as mentioned. Oh, and then it had to be during the fiscal year 2020 / 2021. So anytime between July 2020 and June 2021. And an actionable item we defined as a 2 or 3 rating during T1, and a lower score during T2 is what we defined as an improvement in that actionable item. So as we look through these charts, you want to focus on the orange for match and then blue for mismatch. So match meaning an Asian client was paired with an Asian clinician, and then mismatch can mean that a Black or African American client was matched with a Latina OXA clinician. So what we can tell from this chart is that matched and mismatched providers, for the most part, prioritize the same 3 domains in risks, functioning, and needs. And match has an advantage. They have an advantage, but it seems to be very, very slim. Matching overall seems advantageous when it comes to caregiver items, where matched clinicians are about 10% more likely to improve an actionable rating. And then if we were to look at the x-axis actionable ratings for cultural factors, matched clinicians are almost twice as likely to rate a cultural factors item as actionable, but half as likely to improve the actionable item. We zoomed in for you and to provide some context to this. So we saw that language accounted for over half of the actionable items, 60 out of 114 for matched providers, which makes sense. Or if language was an issue, then the client would need to be paired with someone more so likely that that person would be the same race or ethnicity. So I just wanted to create some background to that and really inform you of why it's necessary to dive deeper into the data that looks significant, because we don't want to create any blanket conclusions just based on what you initially see here. So this next chart is for our slightly younger client episodes. These are all the clients that were younger than 6. And just a couple things I wanted to point out is that 100% of the actionable dyadic consideration has improved for 0 through 5 client episodes, which is astonishing to see in general that there was 100% on there. And then overall, matched clinicians were 15% more likely to improve an actionable item. And this disparity could possibly be credited to working with caregivers, which we'd see in dyadic considerations or the caregiver items themselves. And then dealing with their trauma and bolstering their strengths also contribute heavily with the gap between matched and mismatched client episodes and providers. So we also track down outcomes based on the status of T2. So we are interested here in when we actually discharge a client, do we see different results? And for the most part, you could see that it looks fairly similar to the first chart we showed you, but those gaps between matched and mismatched CANS outcomes kind of widened a bit. So the top 3 items we see, I think we went from like 1 to 2 to 9 and 11. And then the risks went from a 7% difference to almost a 19% difference. At the same time, we saw that big gap, the 10% advantage for the matched clinicians for caregiver items, and that gap has basically closed when we looked at the closing assessments. So up next, we wanted to also look at the sub-ethnicity match. So in the earlier charts, Chinese clients and Japanese clients were considered a match because they were both Asian. Now, within this chart, where we're looking at sub-ethnicity match, that is not the case anymore. Now, they're only a match if it's the same exact sub-ethnicity, so an Arab clinician and an Arab client. So in this chart, we just want to point out that the caregiver gap almost doubled in favor of matching clients to clinicians. And everything else looks about the same, where it's either no difference, or if there was a difference, it's maybe within like a percentage or 2 of what we saw in the first chart. Okay, so this chart is included in this presentation to show the outcomes specific to the African-American/Black community in San Francisco, but also to highlight the disparity between matched and mismatched. So despite the system-wide effort to match clients with providers, as Ritchie brought up, the system is struggling when it comes to the African-American/Black clinicians. Because of this, the correlation strength of the CANS outcomes and matching is weak for risks, caregiver, and cultural factors, where there are relatively just so few actionable items. But we do see some initial trend despite the low numbers. Cool. And then when it comes to sub-ethnicity matching for Asians, there's only a 6% difference overall between matched and mismatched clients, which I'm sure from the chart you can tell that that 6% is in favor of match. But we can see that across the domains individually matched clinicians are more likely to improve actionable items. Also, there's great success in pairing Asian clients of certain sub-ethnicities to providers of that same ethnicity, as we see that kind of flip in the N numbers of match and mismatch. We went from where about 2/3 of the clients' Asian sub-ethnicities are matched with their clinicians. All right, and then here we have the CANS outcomes for white client episodes. So this chart is included to highlight the poor outcomes overall, regardless of the difference between matched and mismatched clients. So white clinicians only improved about 19% of the actionable ratings for white clients, compared to 27% overall for non-white clinicians. Items are missing in this chart because there are just so few actionable items to necessitate portraying that comparison. But that could also speak to potentially, I guess, the ability to see those same actionable items as we saw with other clients of other ethnicities. So these outcomes could also speak to an issue of lumping those identities, especially within white/Caucasian, when we see that, or when we have an idea that life experiences vastly differ between Europeans, Middle Easterners, North Africans, Arabs, Jewish people, and the generational white Americans in general. And in fact, 79% of our white clients identified under this blanket of white Caucasian without specifying further. And then for the last chart, I wanted to show you guys what it looks like within a specific domain. So the first comparison chart only showed a 1% difference between match and mismatch for needs, but zooming in tells us kind of a different story. This chart would suggest that if a client is presenting with attachment difficulties or adjustment to trauma, a provider change to a matching clinician may be helpful for those clients. Whereas with anger control, it had the opposite effect, where it kind of looks like we're leaning towards a detrimental effect if we match, but we don't want to make those assumptions, just something that the data might say. So Ritchie, do you have anything to add to that?
I think we're good with that. And I really appreciate your sharing of this different data stories, Navid. And when we started bringing this data to many for data reflection circles across our system, there has been questions really in terms of, it's good to see trends through time and visualize in terms of like a very powerful way of really just using bar charts to really show whether there is an impact of cultural match on improvement rates in CANS outcomes. But there's also the question about, are those changes significant enough to really talk about like significant outcomes? And so what we have begun to do, and this is just very preliminary exploratory, is doing some form of like multivariate analysis of variance on our data just to see whether clients who are culturally matched with their clinician or provider improve in their behavioral health outcomes. And if they do, what specific items in their CANs do you have the most improvement, or you would really see like a significant improvement? And what we found in our preliminary analysis is that for our biggest populations in our system, our Latina, Latino, Latinx, Latina, and Hispanic populations, these are the CANs items wherein clients improve better and significantly higher if they were matched with their clinician. For the Black African American population, other self-harm and intentional misbehavior were two items wherein if a Black client is matched with a Black provider, through time, you would see improvement in these two items. For the Asian population, it's the items suicide risk, non-suicidal self-injury, substance use, somatization, school attendance, and sleep. And what we're beginning still to have is just preliminary data reflection circles around this, to understand from the perspective of a provider, does this make sense? So in one program that I work with who serve mostly Asian populations, they spoke to, given the focus in the population around like school and related as well to like school attendance, and also the experiences of somatization in the Asian population, it makes sense that for a client who is matched with their provider based on their Asian identity, you would expect like improvements across time around those. At the same time, it's also good to understand, again, following our racial equity data roadmap, using other sources beyond just numerical data or rating scales data in our CANS assessment, in terms of really understanding stories around cultural match and how it impacts the work of a clinician. So for example, in our CANS cultural stress influences item, aside from clinicians really identifying what's the source of cultural stress for their client, they also include like a narrative of how that might look like in terms of the story of the client around that cultural stress. So for example, and usually we use those as a basis for really informing like practice improvement efforts we have across our system. Here are two client story examples included in as part of like our qualitative data storytelling. So here's one from one clinician talking about their client. The client is an African-American preteen male. The client has expressed his anxiety, fear, and anger of the current social and political climate of racism. This was in the middle part of like 2020. The client is seeking an understanding of why someone could hate another solely on the color of his skin. The client asked the clinician, who identifies as a cis white middle-class male, why white people hate Black people. Client expresses sadness over the death of George Floyd and the trauma of watching it on social media. This clinician is exploring ways of responding to this through supervision and consultation with colleagues. So in just listening to that story, that could help us, like for us in leadership, try to understand what might be potentially like training or supervision needs for clinicians who witness these experiences of cultural stress in their clients. Here's another story. This therapist is of a different racial or ethnic background, Caucasian and Hispanic, and has had a different cultural experience and socioeconomic background than the client and her family. At this time, the teen client, who self-identified as Peruvian, and her mother have not expressed any concerns over this cultural difference or reasons to believe it will interfere with client's progress in treatment. Therapists will continue to practice cultural sensitivity and remain open to feedback regarding differences from client and her family. This clinician will provide services to client and her family in English and Spanish. I just highlighted this one story, but what we saw as a theme as we are trying to do some thematic analyses of all these narratives that we hear from clinicians in their assessment forums, we notice a lot of apprehension to really engage in difficult conversations around cultural mismatch with clients. And most of the time, the stance of the clinician is to wait. Well, if my client does not bring it up, that it's a concern for them that they are not matched with a provider, then I don't bring it up as a clinician. So we thought of that as really like a workforce development need in our system. So in terms of, after all that data storytelling, how do we move from data storytelling to action planning? And again, following that racial equity data roadmap, finding ways to make plans to act on disparities that we see that really typify or highlight racism, but also like structural racism in the work that we do, and moving that from data storytelling to action. A lot of that has really paved the way for us for practice improvement steps in terms of reflecting on our current practices around how do we share data, how do we talk about data, to, based on our reflections on the data, from collaborative community ways of really reflecting on the data, how does that help inform the way we could culturally adapt our practices or pave the way for really anti-racist, culturally responsive practice? So one thing that we do around data, and thanks to our quality management department, headed our analytics department headed by Petra Yerman, really creates these very beautiful visualizations of our CANS data. And for the past 2 years, we really represented our data based on race or ethnic groups. And what we did is to make it like a timely celebration of looking at data specific to particular racial or ethnic groups, we coincide data storytelling around the CANS around Heritage Months. So whether it's the Latina, Latino, Latinx, or Latine, or Hispanic Heritage Month, or the Black History Month, or the AAPI Heritage Month, we make sure we share data around those times around our CANS assessments in an aggregate level specific to that group, and conduct like data reflection circles around it, and also find ways to help inform our clinical practice around that. So this is an example from our most recent one. We also are aware that we are still in the midst of our Latina, Latino, Latinx, Latine, and Hispanic Heritage Month. So what we did is different for this past year is to really look at disaggregated data. As we are talking about the CANS stories of clients from the Latin American population, we also recognize that it's not a generic community, wherein it's not a homogeneous community. So really looking at like disaggregated data, trying to see what are the stories of needs and strengths specific to subgroups of this population, whether it's Central American or Caribbean, Mexican American or Chicano, other Latina, Latino, Latinx, or Latina populations, and even those who identify as multiracial or biracial. So for example, Black Latinx or Afro-Latinidad populations. And in terms of looking at practice, here's just an example of how we think about practice for our clinicians. Like, of course, we understand for many of practice, it needs to be supported by evidence-based practices. So as much as we support our different providers and clinicians around making sure their evidence-based or use of evidence-based practices is strengthened throughout the year, we also make sure that given that in our data storytelling that we have disparities in our cultural matching, so whether clients or clinicians are matched or mismatched with their clients, it is important for them to support the work around, one, having them become more comfortable in this anti-racist work of having difficult but constructive conversations with their clients around race and also ethnicity and experiences around race and ethnicity like racism, discrimination, racial traumatization, and many others. And at the same time, being very deliberate and intentional in terms of making sure a lot of our evidence-based practices have a venue for really allowing clinicians to gain more competence in cultural adaptation and being more culturally responsive to their client population. And of course, pulling all that together as well in our current work of doing telehealth or hybrid telehealth with clients. So before I end and really open it up for discussion and also some Q&A, key takeaways from this is really, first, in our work around QI, as we are highlighting stories around our CANs in our system, it's really good to anchor those assessment and QI efforts within our system values, because then we get a better buy-in in our provider population, but also in our system in terms of really aligning efforts around it. So within our system, it's really our racial equity plan and also our trauma-informed systems that became like key pillars in doing this work. At the same time, to strengthen meaningful assessment and QI, we often look for opportunities to adapt and to adopt anti-racist and culturally responsive frameworks as a way of really framing not just the data storytelling, but the way we use our aggregate data storytelling to help inform clinical practice improvements. So that's it for our presentation. Really appreciate you listening to Navid and I, and now we're opening it to some Q&A. I see in the chat too, there's a question, has any work like this been done about the LGBTQIA+ community? Thanks for that question, Gary. And for us, it's still beginning in our system because we also know that even in this work around paving the way for culturally responsive or culturally attuned work, most of the time, especially in the beginning, it might be limited to thinking of diversity in terms of like race or ethnicity. But we also understand there are many other aspects of diversity. So that's definitely something that we are looking at down the line. When we think about like cultural matching, it goes beyond just racial or ethnic cultural match, but also looking at match based on other levels of diversity like SOGI, sexual orientation, and gender identity. Given the nature of evidence-based practices often created with research based on white people, has there started to be an increase in improvement of evidence-based practices with more broad populations, since there is now an inclusion of cultural matching? That is a great question, Josh. And oftentimes when we have conversations about evidence-based practices in our system, we highlight that. And we recognize that most of the time, especially evidence-based treatments, they have been proven as effective based on a particular population, most of the time a white middle-class population. And so in our system, it's really being intentional about recognizing that there are imperfections in the use of evidence-based practices, and there is a bigger need to really bring to our system culturally defined practices, and that is starting in our system as well. But at the same time, for clinicians or providers who have been trained in many of these evidence-based practices, really having a lot of opportunities by which they learn how do you deliberately do cultural adaptations in the use of like CBT or trauma-focused CBT or even like DBT. So for example, there's this recent work from Yale around anti-racist DBT. So that's something that we are starting to bring in our system as well. Like with DBT, knowing that it's an evidence-based treatment, but also acknowledging its imperfections in terms of not being culturally responsive, really how do you integrate it with anti-racist work? in the way you navigate the different like skills or principles of doing like DBT. And Ellen has a question here. What is your system's response to matching clients' data been? Are there plans to address the gaps in staffing to mirror your clients? Yes. Thanks, Ellen, for that question. And definitely what we showed here is really the implications of the data matching on clinical practice improvement efforts. But at the same time, we have used this data a lot, and more specifically with the work of Navid, really sharing the data that is program specific. So as we share that data to each of our programs and also as a system, then we have really conversations about where are the gaps in our workforce population. And we use that to really influence our hiring and retention decisions that we do. Or even, when we are trying to portray what are the clinician needs in our system, really highlighting, do we need to specifically look for particular race or ethnic groups in our clinician population based on the cultural match disparities that we see in our data storytelling. So yes, Ellen, yeah, we have used it. And in terms of the response, it was, a lot of our system really appreciate it, because many times they don't really see that live, like in day-to-day like operations of their system. So it's good to see that, to see that data on like an aggregate level. Another thing that we're also looking at right now in terms of cultural matching is to really understand that it's not only match one-on-one. And part of the cultural match that now we are portraying in our system is also looking at it based on job classifications. So what does the cultural match look like in the administrative staff population? What does it look like for the provider population? What does it look like for the leadership population? And what we saw so far, which of course, it's not something that surprises me, in terms of really mirroring the community that we serve, most of the disparities happen in the leadership level, wherein we don't have enough leaders that really mirror the race or ethnicity of the client population that we serve. Thank you so much, everyone. Really appreciate you joining us today, Navid and I today for this presentation. Really appreciate it.